What up, friends? Hello. Sorry, let me fix my screen real quick. It's very dark. Turn the brightness up. There we go. There we go. Much better. Hi. I'm Bree. If you're stumbling upon this, I'm a nurse practitioner. I'm getting ready for my night shift. This is my weekly Get Ready With Me, where we talk NP stuff. Sometimes clinical, sometimes professional, and it tends to bounce back and forth. This week it's going to be clinical. And we're going to be talking about how you can tell when it's time to extubate your patient. So this is really going to apply to my ICU ER friends. Yeah, so that's the topic for today. Typically, let me fix that. Typically, it coincides with the blog post I did that week, but I'm a week behind. So if you are following along with that, it's a little delayed. This was 2 weeks back that I wrote this. And I'm going to multitask, and we're going to talk while I get ready. So thanks for joining me. If you've never come on here before, this is an open space. Feel free to ask whatever you want, including, where's my lotion? There it is. Pretty much anything. If it's super duper personal, I'll just tell you. But I welcome all questions, feedback, comments. It's always nice when I have different opinions on here because I don't want to present like just my bias. And clearly I have, everybody has bias. So, all right. So in this blog post, at the very bottom of it, if you are on my mailing list and you've got it, at the very bottom is a quick checklist, and that's sort of the abbreviated version. And there are 11 steps to take before you can extubate somebody. Well, should extubate somebody. And this really just involves assessment, exam and assessment, because the whole thing is mitigating risk and trying to fully understand what the risks and what the pros and cons are, the benefits and the risks, and assessing those properly so that you can make an informed decision going into it. It's not always black and white, but as long as you have a pretty good idea of what risk you're assuming, we definitely want to liberate people from the ventilator as soon as humanly possible. That's our goal every day when we round in the ICUs. How quickly can I get that ET tube out of this person's mouth? Hey, Alex, it's that time of the week again. Woo woo! I love it. Thursday is the new Friday, I feel like. Unless you are the kind of person who works on the weekends, in which case it's Monday. And since a lot of us do shift work, we're all over the place. But even still, the rest of the world's celebrating, so maybe we should. I'm looking through my blog post, refreshing what I need to say because I don't prepare in advance, and just refreshing my brain. And one of the things I have scrolling on this is something that my mentor, the person who set up the program where I work, has always said over and over again. If you have a 0% fail rate when you extubate someone, as far what I mean when I say fail rate is you take the breathing tube out and then you have to re-intubate them either right away or within, a 12-hour, 24-hour window, something like that. We consider that kind of a fail. But fail is got a negative connotation to it. And I don't particularly love it because if you have a 0% fail rate, you are not attempting enough. I mean, we should be overly aggressive about trying to get this ventilator off, trying to get this tube out. And so a lot of times it is a little bit of gray zone. It's not always black and white. We look at all the factors and we say, okay, let's take it out. If it doesn't work, we'll put it back in. You can always put it back in for the most part. There are a couple caveats to that. But either way, you should always be super duper thorough in assessing whether or not this patient truly can come off or not. And I wrote this because sometimes I look back on myself as a nurse, and I was a nurse for 15, 16-ish years before I went back to school. And I spent a lot of that, probably about 10 years of that in the ICU. And the hubris that I had as a nurse, the things that I really thought I had a good handle on, the things that I used to judge providers on doing or not doing, is a little bit embarrassing when I look back on it. Because honestly, you don't know what you don't know until you know. And this is one of those prime examples of, I was always like super duper eager to get that tube out as a nurse. As soon as the patient woke up, I was on the phone like, all right, let's pull the tube. They're awake now, because in my mind, if they're awake, they can breathe. Let's take the tube out. So naive. And I think part of that comes from a place of, if you work at the bedside and you're dealing with a patient who's intubated, who's agitated, the pain and the suffering for everybody involved, the patient, you, everyone. It is a horrible place to be in life. And nobody wants an awake, agitated patient on a vent. Nobody does. It's not good for them either. We don't either. Providers don't either. But just simply being awake does not indicate that they're ready to come off of a ventilator. So this is one of the things when I was in school and training that once I realized the very easy and systematic way of just looking through everything makes it so simplified. And anything to me in medicine that you can make into an algorithm helps, particularly when you're new, because everything is so overwhelming. And this is one of those great examples of this. You do the same things for every single patient with one-ish exception, and it gives you a lot of great data. And again, you may not be 100% sure. A lot of time it comes down to gestalt, but at least you have a pretty good weighing of the balance of the pros and cons that you're assuming. So that's my preface to the whole story. Step one, and probably the most important thing, and this is what I failed to account for as a nurse, is have you properly diagnosed what the problem was? What caused the respiratory failure? Was it hypercarbic? Was it hypoxic? Was it both? Was it an airway threat issue? So multiple different things necessitate the support of a mechanical ventilator. And you have to first and foremost diagnose what the problem is. And some of these problems will turn around really quickly, AKA your overdose patient. Your COPD patient tends to turn around pretty quickly. These are people that you put them on a vent and then the drugs wear off, or you ventilate off the CO2 and suddenly they're more awake and they're no longer bronchospasming and you can get them off pretty quickly. But other things like pneumonia, particularly pneumonia in an immunocompromised or an old person, it ain't going to turn around quick. So you have to have a good understanding of what the problem is, because it helps you anticipate, how bad it is, how long it's going to last, what the risks are in taking it out. Someone with Klebsiella or MRSA pneumonia is going to produce a lot of secretions. They better have a really darn good cough. And this is how coming to a diagnosis helps you to narrow your focus in what the risks are coming off of it and what to anticipate that you can fix before you get them off. It also helps you to prognosticate whether or not they are even able to come off eventually. And if it's something, particularly, I always think of neuro stuff like big catastrophic stroke, brain injury, that kind of thing. It's not going to turn around quick. You're talking months probably. So just if they're not going to be able to support their airway, just go ahead and trach them early, because you can reduce all of those risks that go along with prolonged intubation, like ventilator-associated pneumonias and permanent vocal cord damage. All of these things can, and they're also more comfortable once you get past this little spot right here, which when there's pressure against it, what we're trying to say, prompts your gag reflex and makes people agitated on a vent. So trachs are good, particularly in people that aren't going to improve quickly. So the first step is, why were they intubated? And you need to have a really reasonably good explanation. Sometimes it's multifactorial, but again, you need to know what was wrong. And the second thing is this problem resolved or not? Not saying it has to be completely resolved, but it needs to be in a stage in which it is vastly improving, and or it's improving enough that you have less risk when you take the breathing tube off. Okay, and so then within this section, I talked about glasses on, glasses off, glasses on, glasses off. I'll have to tell you my glasses saga maybe next week. I don't know. We got too much to talk about today from our personal drama. So if it is not resolved or even reasonably resolved, you have three options. Discuss trach, discuss the diagnosis and prognosis with the family, and determine goals of care. So sometimes these are the patients that, like, when say that I intubate them in the ICU, and I think it's something that's going to take a little while, I will often have the family and or the patient, before they even go on the ventilator, give me a time limited frame. Like, how long do you want to continue this, trying to improve this, before we say we're done and we're either going to stop or we're going to trach. Understanding time frame and where you're at in the recovery versus non-recovering phase. I put the glasses back on so I can finish. And then the third option is just give them more time. So there's really no set time frame for how long a patient can stay on a ventilator. Now, pre-COVID, we used to really stick to the 7 to 10 day time frame. Around 7 to 10 days, if they're not getting better at a reasonable rate or an expected rate, we're already starting to bring up the idea of tracheostomy with the family. And then planning to try and get it done within a 2-week time frame, because there is some evidence to support that that's about when your risks of VAP or ventilator associated pneumonia go up. Now, COVID, I feel like kind of changed that. I'm sure a lot of you guys have worked in the hospital during COVID, and you're aware that we left people on BiPAP for, sometimes months, and we left people on a vent without tracheing them sometimes for the entirety of their duration of their stay until they died, because we could not safely do a tracheostomy because they were on so much FiO2. So I feel like pre-COVID, it was a lot more pressured. The pressure was on to get that to about within a week to 10 days. Now it's kind of like, yes, it's there, and yes, the evidence is still there that we should, but it doesn't feel as pressured to me. I don't know. Maybe this is just my anecdotal impression. Y'all let me know what y'all are seeing out there, but I tend to not be. There's too much crap on my. It's a good thing you can't see the surface where I'm at. There's so much stuff in here, y'all. It's not real pretty. Bear with me. Yeah. So my point was. You may be in a situation where the family's not ready to make a decision, or maybe it was a situation where, say, it was an old person with dementia and they have a pneumonia, and the family is aware that they don't really want to go down the road of tracheostomy, but they also aren't really ready to call it quits. This might be a situation where you're like, let's just give it a few more days. Let's extend it another, 5 days to 7 days, give it another week, and then we'll just see. What's it going to harm? Well, it could cause harm. But as long as you're making an informed decision with the family and the family's aware of this, I think it's perfectly a reasonable option to do that. What did I say here? I think it boils down to diagnosis, pre-hospital health of the patient and their ability to recover, and the family dynamics. Exactly. That's exactly what I said. Had a couple of cases lately of cardiac arrest where this is the case. We leave them on the vent knowing that we can't take them off, but they're not quite ready to commit to what we need to do. And that's okay. This would be the getting ready phase. Because even at nighttime, nobody needs to see a bare face. Although my rosacea, I saw my dermatologist this week, and it's like cured. I'm going off the antibiotics and just sticking with one cream. I'm so excited. I looked for 2 years for someone to cure my rosacea, and I didn't think I would find it. I know this is vastly thrilling to all you guys. I end up having far more gentlemen that join me on here than ladies. So I know that this is just thrilling to y'all to be talking makeup and skin. All right. Let's see. So, I forgot. There's one more bullet point under the whole section of why they were intubated. And that is assessing, what do you do if the problem is not completely resolved? And my example for this is like pneumonia. I think pneumonia is a good example. There are plenty of people who are on a lot of FiO2 support for pneumonia, but they're not intubated. So just requiring a higher amount of oxygen support doesn't, in and of itself, doesn't mean that they can't come off of the ventilator. So, but you just got to weigh all those factors. Are they old? Do they have the ability to cough up secretions? Do they have the ability to support their airway and recover at all? So you may really, truly be willing to accept some risk as long as you know what it is. Hey, Scott, I'm actually shopping for groceries this time. That is multitasking. The worst time in the world for me to grocery shop is after a shift, even if it was a day shift, because I make poor choices when I shop like that. So kudos to you for getting it done on a day when you're not working. I'm also in the season of not wanting to cook anymore, so I could leave the shopping to everybody else in my house and be just fine with that. Okay, step number 2, what is the neuro status? So I'm starting from head down. This is how I kind of just sequentially go in the room and look at a patient and determine if they're ready to extubate. Um, it takes, in reality, this is going to take a long time to discuss. In reality, it takes less than 5 minutes to do. But it starts with neurological status, and you really need to have a good perception of the neuro status, more so than just the nurse saying, well, they're awake and they're following commands. So I'm glad that you're home. Okay. So the dog's barking because the school buses are starting to arrive in the neighborhood. Makes him so happy. We have a barker. But what am I doing? This one. Okay. GCS. So that's your, I have to look it up every single time, but your motor function, your sensory function, your orientation status. So working through that and starting with what drips are they on, because some of these folks are still on sedatives and or pain medications and completely alert and oriented. I don't love to extubate people when they're still on drips, but sometimes we do, particularly if it's just a little bit of Precedex. But everybody responds differently. 0.2 of Precedex for an alcoholic is like, why are you even trying? 0.2 of Precedex for a grandma who is very opioid and benzo naive, even though it's neither one of those, is still maybe enough to just completely shnocker her. So very, very different for everybody. So minimal sedation as it takes to get a proper neuro exam. So start with your GCS, and then do they understand you and do they follow commands? So beyond just, are their eyes opening? Are they regarding you? Regarding is another way of saying tracking. To me, it sounds more like medicine-y and makes me feel better about myself. So I always say regard. I think that's just because I trained a little bit in a neuro ICU for a hot minute and they all said regard and it made me feel like they were super smart. So I use the word regard. This is how you actually fool people into thinking you're smart, y'all. Brushes. Where are they? They're always behind the computer. So are their eyes opening or are they looking at you and following you around the room? And then beyond that, do they understand you? And the way that we assess this is by saying, do they follow commands? Well, I find a wide variety in what people say, oh, this person's following commands, and you can be assessing them at the exact same moment and get a totally different view of what it is. Because there's a lot of factor of reflex that goes into this. In the ICU, as nurses, we're trained to ask them to squeeze our hands, which to me is really assessing more motor function than it is. I mean, in some ways, yes, you can assess neurostatus there. Like, do they understand you? But my caveat to this is there's a reflex there, okay? There's a reflex there, and I don't know that I always trust it. So it's not my favorite way. If you must do something with the hands, I say ask them to give you a thumbs up or put 2 fingers in the air or something like that. But the problem with this is, say you have a patient that has like critical illness myopathy where they're awake, they're completely neurologically intact, they just can't move anything, almost like a locked-in syndrome. So if you don't account for that, like somebody who's been on steroids for a long time, like our COVID people, somebody who has like a Guillain-Barré, somebody who has motor function decline, they may not be able to do it simply because of muscle strength, not neuro status. So I don't love hands in any way, shape, or form for assessing whether or not a patient is understanding you and following commands. My favorite thing to do is ask them to stick their tongue out. Even with an ET tube in the way, they can still attempt to do it. Almost always. If they understand you, they will be able to do it. The tongue has a lot of muscles in it. It's very easy to move, even if nothing else in your body is working. It's very specific, right? People aren't just going to randomly be sticking their tongue out. So it's very, very, if you ask them to do it and they do it, they understood you and they're able to follow commands. The other one, if you can't do that or you can't see it or they have a lot of angioedema or something like this, ask them to look certain ways. Not blink, okay, because blinking is subjective, but ask them to look up as a yes and down as a no and ask them a series of questions. That's my second most favorite way to do it. Okay, so that's assessing whether or not they understand you. And the GCS. So those 2 things. Then I move on to pulmonary mechanics. So what I mean by this is looking mostly at the ventilator and the interaction between the patient and the ventilator. So starting with the ventilator, really and truly, you want your FiO2 to be 30%, lowest. You can extubate people on 40 or 50%, depending on what the diagnosis is. So there's some gray there. You can always extubate straight to BiPAP or straight to vapotherm. Like in syndromes that create a lot of hypoxia, but not as much dyspnea, like COVID, like ILD, fibrosis, all of those kind of things, it's perfectly reasonable to take someone off on a high amount of FiO2 and just go straight to a high amount of FiO2 support without the pressure support, because what you're taking away then is just the pressure support. The second thing you're going to look at is, do they have any apnea? This is one of the most common alarms that you will get when a patient is on a CPAP or a spontaneous breathing trial is apnea. And y'all know I struggle sometimes to say things nicely. One of my pet peeves is when if I'm trying to trial someone and get them off of a ventilator, I really, really, really want good objective feedback about what went wrong and why we couldn't do it. And it's rare that I actually get it, no matter who I'm asking, whether I'm asking the RT or the nurse. What I hear is one of two things. This is it. They went apneic, and so they had to go back on, or they were agitated and they had to go back on. Well, neither of those two things really tell me anything. If you're telling me that they're apneic, I need to know what the settings were on the ventilator. And I also need to know what sedatives they were on. So, because it very well could be that they're apneic because you had just that 0.2 of Precedex there. And that's all I need to do to take it away. If I don't know what the factors were contributing to the apnea, I don't know what to do or to change. And I'm not the one at the bedside, so I don't know the details like they do. So I love it when nurses can give me more specific feedback. It is rare that I can actually get it though. Okay, so with apnea, two things I'm looking at, aside from the sedation, which we already talked about. The next most common thing that people fail to count for is, do they have a metabolic alkalosis? Yeah. So metabolic alkalosis, if I have a patient that I'm told they were apneic and they had to go back on the vent, I'm going to be looking at the sedatives. I'm also going to be looking at anything non-obvious sedatives like gabapentin, like Seroquel, like all the atypical stuff that we give for delirium. That stuff can all make people apneic as well. So make sure all of that stuff is off your profile, first and foremost. Secondly, I'm going to get a gas. And if they have a metabolic alkalosis, the body's way of compensating for that is respiratory acidosis, which is reduced ventilation so that the CO2 can rise. The carbon dioxide level can rise to buffer. So this is a common scenario in which they're in the hospital and we create a metabolic alkalosis because we diurese the crap out of them. So they get this metabolic alkalosis and then the body goes, we need to retain some acid. So let's slow down our ventilatory status, because the respiratory response and ability to buffer or compensate on an ABG is the fastest way to do it. So if you have a metabolic problem, the respiratory response is going to be quick. And the body knows that. It's super duper smart. So it's going to slow down its respiratory rate. It's going to slow down the tidal volumes. It may even become completely all the way slowed down. So if you get a gas and they have metabolic alkalosis, you know what the driver is for this apnea. So fix your metabolic alkalosis, and then the respiratory acidosis will get better. But you have to not just stop when someone says they failed a trial. You have to investigate and drill down into why, so that you can change things. Because if you don't, then it's the definition of craziness, because the next day you're doing the exact same thing without making any changes. It doesn't make any sense. So apnea. Okay, so FiO2 settings, are they having any apnea? I think I will go ahead and, where do I talk about agitation at? Should I go ahead and talk about that? We'll just keep going. We'll keep going. The next part under the vent settings is really kind of looking at the x-ray. So here's my caveat about x-rays. X-rays, pictures lag behind the clinical scenario. I mean, it starts with your patient. Like if they have a Klebsiella pneumonia and they were requiring 100% FiO2 2 days ago, and suddenly they're down to like 40, 50%, it should be improving. Your x-ray may not quite show it yet though, because the x-rays lag. You're going to see the patient get better far before you'll see the x-ray get better. So I would not place all of my decisions about whether or not to extubate or not to extubate on an x-ray. It's just one piece of data, but it can be very helpful. If you open up a series of x-rays for this patient who's been here for a week and they have profound infiltrates or like white out on one side, you probably not want to adjust that before you extubate, So x-rays do matter. It's part of it. It's just one part of it. Yeah, so I said just look at the trends. You don't need a pristine set of lungs, but really it should be looking better than when you started. Yeah, I think that's all kind of self-explanatory. And ABGs. Do you need an ABG to extubate someone? Well, I kind of told you in the above setting why I would get an ABG. But do I need to have an ABG to extubate someone? Not really. Some of it kind of depends on what's going on with the patient, particularly someone who, like a COPDer who's had major ventilation issues. One could argue that you would want to see, improvement, if nothing else, on your ABG. But it could have been improvement yesterday. Do I need to have one every 24 hours? No. There are other surrogates you can use to determine if the hypercarbia is corrected. Number one, the most important one to me, is neurological status, because as the hypercarbia goes away, they will wake up and they will understand you. A patient with a CO2 of 100 is not likely to be awake and talking to you. So by default, it's probably improved. You can also trend in titles, which I love to do that. It's kind of a pain in the butt to get set up and find one. Not everybody has them, but you can trend in titles. You can look at the measured in title CO2 on your ventilator. And again, but my caveat to this is it's got to be trend wise. You can't just walk into the room and see what your numbers are and automatically say, okay, this is a high number, this is a low number. You have to compare it to where it was. And probably the same could be said for ABGs. But if you don't have access to those, that would be the indication in which I would probably get an ABG before I extubated. Outside of that, I'm not sure I would, because hypoxia, I don't really need an ABG for that. I don't. I can look at the monitor, unless the patient is in profound shock on a lot of pressors or has terrible peripheral flow, or is very, very either hypo or hyperthermic. If none of those factors exist, then just look at your monitor. If they're 95% on 30% FiO2, they're not hypoxic. Who cares? You don't need an ABG to show that. Alex said, so would you fix the metabolic alkalosis with permissive hypercapnia? Yeah, I think it's fine to do that. The problem is just that if you're actively trying to wean someone and trial them and get them off of a ventilator, that's not really going to help you. It may slowly resolve on its own, but probably what I would do is address the metabolic alkalosis. So you can get a urine chloride level and see if it's a contraction alkalosis and give them some volume back. There are a few things like that you can do to try and reverse the alkalosis, and then they won't need to have that permissive hypercapnia. Or sometimes the other reason this will happen is because, say the patient had worsening renal failure and we put him on a bicarb drip and we left him on it for way too long. Typically speaking, metabolic alkalosis is something that we do to people. It's not always something they come in the door with. It's not the most common. A lot of vomiting, a lot of a lot of things that can occur while they're in the hospital is kind of my point. So you could be watching your trends there, or you could just be looking at the CO2 on your CMP. You'll see it trending over time. All right. So the second part of the pulmonary mechanics, so that was all talking about the ventilator and the lungs kind of. Now we're going to talk about the trial in and of itself, which I sort of alluded to already. We talked about what an apneic trial, what that looks like. But there's a very specific set of information I want to know when people are on trial. And one is this: how much FiO2 are they on and how much pressure support are they on? Because a pressure support, and this is pressure that the ventilator is giving to the patient in the form of either applied pressure or volume. This is being supported by the machine and given to them. And we, as the dialers of the knobs, can determine how much is given to them. And it can be a little bitty bit, or it can be a heck of a lot. And I think of pressure support as it's CPAP, right? So it's like if you stick your head outside the window and you're driving down the road and air is being shoved in your face, that's pressure support. When air is being shoved in your face, if you've ever been skydiving, you know this as well. It's super duper easy to take a breath in. It's easy to suck air in because it's actually being kind of like pushed in. I remember skydiving and having a hard time exhaling because it was like, because it was just being constantly pushed in. So the more amount of pressure being pushed in, the less work the patient has to do. So if somebody's doing very, very well on a CPAP trial, but the pressure support is set at 20 or 12 or some high number, they're not doing a lot of work in and of themselves. So yeah, they may look okay. The hemodynamics may look okay. They're nice and calm. They're not dyspneic, but it's because the machine's still offering a ton of support to them. And this is going to be harder to administer to them via a CPAP mask. Now, having said that, there are people who can go on trial with, I would say, anywhere between like 5 and 10 of CPAP. And if they're doing kind of okay on that, this could certainly be someone that if you have concerns based on what the diagnosis is, you can have a BiPAP or CPAP machine in the room and you can extubate to CPAP. You can just go straight to it. We do this a lot. So you have to remember, just like when we're ramping up a patient who's getting worse, there are different levels of things we can do to support their breathing before we get to a ventilator. The same thing can be done when you're weaning down. You don't have to go straight from a ventilator to room air and be fine. You can sequentially stepwise down. You just have to, again, assessing risk and what you think the potential rescue methods would be. Okay, so all right, yeah, so I talked about pressure support. Pressure support and PEEP of around 5 is kind of what I'm looking for. And I'll tell you about the specific things I'm looking at on the trial to tell me that they're passing it. But I want to give you another little side tangent here about pressure support. And this is because the greatest failure of my career as an NP was involving a patient with heart failure that was on CPAP trial. I don't remember how much pressure support she was on at the time. And she was a young person and she had terrible heart failure. So anyways, we were doing a trial. She got agitated. I was a brand new NP. I go in the room. She's understands us, but she's kind of all over the place. She's very, very agitated. So she's tachypnic. It's hard to talk about because this is when you fail or you do something as a provider and something bad happens to your patient, it never, ever goes away. It is, I know as a nurse, you have those same things. I have those as a nurse as well. But the burden of liability that you carry as an NP is, I can't even tell you how exponentially higher and harder it is to deal with as a provider because you are directly responsible for these people. And in this situation, I fell prey to some of my nursing instinct, and that is, okay, the patient's awake and she's agitated. This is going to be a pull and pray. And that is also what the RT had mentioned and one of the other nurses. So I fell victim to kind of that and the influence of that. I did have a moment's hesitation, but it wasn't enough for me to stop and reevaluate. 2 of the nurses in the room did bring concerns, and I did not listen to them. We pulled the ventilator. She went into flash pulmonary edema and became hypoxic and coded. She did not die. We got her back. We resuscitated her, put the tube back in, but it was a good, 20, 30 minutes. So very concerning that there may have been a hypoxic injury and all of the guilt that kind of comes along with that. So I tell you this story as a cautionary tale because people with heart failure are different. When someone has heart failure and they are on a ventilator, let me talk for just a minute about the physiology of it. Did I already do this? I did already do this. It's important because of these very reasons. But so when the heart is failing, it can't handle preload and it can't handle too much afterload. It needs afterload reduced and the pipes opened up and vasodilated so that blood can flow more easily out of the heart. It doesn't have to work as hard. From a preload standpoint, it wants reduced volume coming in because the heart is already overworked and overloaded. So you want to offload the heart with diuretics. When you put someone on positive pressure, whether it is CPAP, like non-invasive positive pressure, or put them on a ventilator, pushing air in the lungs, that is taking a chest cavity that is used to having negative pressure and changing it to positive pressure. And what that does is it reduces preload because there's more air, there's more pressure, there's more intrathoracic space. I don't know that I'm saying that's properly, but your preload, those vessels that return the blood to the heart are going to be compressed a little. And so you're not going to get all that blood flowing back to the heart. You're also going to have improved afterload. So because of those two things, the heart is suddenly like, it can just relax. It can take a breath. It's not working so hard. The inverse is absolutely true as well. When you take that positive pressure away and suddenly they have to suck in deep breath and they have all this blood returning to the heart and the afterload is back to being what it was, it makes the heart work harder. And so these people, if they are not ready, if the heart failure is not optimized, will go into immediate flash pulmonary edema. Another way of saying this is negative pressure pulmonary edema. So people who are in drowning incidents or what am I trying to say? When they choke themselves, they can end up in negative pressure edema because they're sucking so hard. And so this lends itself to an emergent, like immediate response of massive pulmonary edema. They literally just drown and they will become hypoxic and they will code. So your heart failure patient needs a different kind of trial than everybody else, particularly bad heart failure. You need to put them on a very, very, very low amount of pressure support. I like to put them on a pressure support of 0 and a PEEP of 0 or ZEEP. None at all. And most people don't do this because this is not actually physiologic. You typically want to apply amount of pressure support to account for the dead space of the tube. You don't want them to have to apply pressure to suck through this tube. That's not what they would be doing in real life. Normally, you and I aren't sucking through a straw. But here's my theory. If you can prove to me that you can breathe while sucking through a straw and your hemodynamics are stable and you're not dyspneic, for a short period of time, okay, then you can absolutely breathe normally. So it is a test. It is like making them sprint for a little bit and seeing how they do. And if they can sprint, then they can walk. So they will do fine. You just can't do this for a long period of time. If you're going to do a ZEEP trial, it needs to be 15 minutes, 20 minutes, no more than 30 minutes. You do not want to put them in major stress. But this is what I do for heart failure because I have been burned because of what happened. So heart failure is different. That's my story and I'm sticking to it. Heart failure is different. Okay, what's the next thing? Now, in regards to looking at the ventilator and the patient to determine if they are passing the test. So you've looked at it, they're on low FiO2, they're on low pressure support, say it's a pressure support of 5, PEEP of 5. That's great. And you look at something called a rapid shallow breathing index or RSBI. Most ventilators have a view where you can see it. It's already automatically calculated for you. It may not be the initial view though. You may have to change it, get your RT to show you. But say you don't, it's real simple. It is just respiratory rate divided by total volume. Right? Yeah, always make sure I say it right. Respiratory rate divided by total volume. This number should be under 100, well under 100. And what this means is, okay, so the higher the number, the harder it is for him, the worse they're tolerating the trial. So if it's, what happens is this, when our bodies are in a state of stress, it is easier to breathe fast and shallow than it is to breathe slow and deep. I'm pausing for dramatic effect. It is easier to breathe fast and shallow than slow and deep. So if our lungs aren't ready, then we are going to breathe fast and shallow because there's still a bunch of pneumonia in there. The compliance is still poor. We've got to give it more time to correct. They're just not ready. If the RSBI is 95, 120, and they are probably also going to be dyspneic. They're going to be labored. They're definitely going to be tachypnic. They may be a little hypoxic. They ain't ready yet. Interestingly, if you are anxious, say someone is hyperventilating, they are breathing fast, but they are also breathing deep. They're breathing fast and deep. Somebody who has lung pathophysiology, that is tachypnic, they are breathing fast and shallow. That's the difference. That's kind of how you can tease out whether or not, is this patient tachypnic because they're just suddenly no longer on Versed and they have gotten used to Versed for 5 days and they're agitated because they have a tube in here and it's uncomfortable? Or is there some pulmonary reason why they can't breathe and so they're breathing fast and shallow? This is how you tease it out. So there's that. And then how are they hemodynamically handling the trial? Because if you've got a lot of tachycardia, if you've got a lot of hypertension, and they're agitated, this is concerning. Suddenly being off of the sedation can contribute to this. If anxiety is the sole cause, you should be able to talk them down, and you can look at that RSVI piece of things. And you should be able to see like some temporary improvement versus someone who's got major lung pathophysiology. You're not going to be able to talk them out of it. And are they maintaining saturations on the low settings while on this trial, or are they getting hypoxic? Okay, let me take just a brief second and switch over to some eyeshadow because it's 3:41. Okay, we're doing fine. Doing just fine. Yeah, I think I'm gonna do this one. We've had a lot of young people at the hospital lately, and I never like having young people. I'm very happy with my like septic grandpas. That's my jam. That's my jam right there. Or people who've made poor or questionable life choices. Not because it's like justifiable, but because it's a little bit less traumatic, you know? Today is the dropsy day. I know y'all love it. That one was the phone though. We need that one. All right, so step number 4, functional mechanics. All right, so you've already assessed your neurostatus, you've looked at the drips, you've looked at the vent. Now you're going to look at the, and you looked at the x-ray, looking at the pulmonary mechanics. Now you're going to look at the functional mechanics of the patient. So this is really looking at motor function more than anything. So this is where you want to make sure that they have the strength to maintain their airway and clear their secretions, and it's pretty straightforward. So the first thing you're going to do is you're going to ask them to cough. You want them to show you a pretty robust cough. And depending on what's wrong with them, I know I keep coming back to pneumonia, but it's just so prevalent. Pneumonia is one of those diseases that creates a lot of secretions. And so for some people, depending on how bad the pneumonia is, the type of pneumonia, their debility level, you know, the patient with dementia who's already probably having some aspiration, your index for suspicion that they're not going to be able to control their airway is going to be way, way higher, lower, worse, right? So you're going to want them to demonstrate for you a good solid cough to show that they can clear all that stuff up. Then you're going to assess their gag reflex, which is their airway protection, right? So if they're eating and they get a little bit of food in the wrong place, are they going to gag? They're going to cough. The way I like to do this, so I've seen it done 2 ways. There's a physician that I know that he'll go in and basically take the tube and just kind of wiggle it around. Sometimes you'll get something from that. I often don't find anything from that though. I like to take that flexible suction, the long ENT suction catheter, the soft one, and stick it back as far as I can. And that will generally elicit a gag if they have one, unless they're on sedation, particularly if they're on opioids. So if they're on a fentanyl infusion, that gag is really going to be suppressed. Gag and cough is really suppressed with opioids. So you'll want to reduce that if you don't have that. Okay, so cough, gag. You're going to want to find out. So I asked them to lift their head off the pillow, and this is really looking for neck mobility. And some of this is to help you determine muscle strength, but also to help you determine if you have to re-intubate and you have someone who has a fused neck, it's really, really hard because hyperangulating in order to get the airway open is very challenging. So it helps you to kind of see that as well. Okay, so cough, gag, lift your head up. And then, oh yeah, can they take a deep breath on command? So ask them to take as big a deep breath as they possibly can, and then look at your exhale tidal volume, because that's what our vents measure. You really want to see something close to like 900, 1,000. I don't I'll be honest with you. In reality, I don't always see that, but that's what you're really kind of looking for. Now, people that you want to be concerned about this with are going to be like your Guillain-Barré, your functional paralysis patients, myasthenia gravis, because they don't have the diaphragm strength and the chest wall strength to pull in deep breaths. So you want to really, really get a good assessment of this. And typically, we don't leave it with just take a deep breath. We will measure something called a NIF, which is your negative inspiratory force. Patient has to be able to cooperate and follow commands in order to measure that, but that's one thing. You can look at the ABG and see if they're getting more acidotic, meaning they're not ventilating well. And there's something else on Drager's that you can do. Something one. And it tells you how much force they're generating in the first second of a breath. I can't remember what it's called. But all of these kind of factors are going to be way more important on someone who has neuromuscular problems, which is sort of less common. That's not the common thing that we have, but you do get them. Where'd my glasses go? Can I take a deep breath? Yep. Yeah, okay. The next step, I think we're down to number 5, is there a cuff leak? And I follow that up with doesn't matter. Because I would say probably about half of the cuff leaks we check, you don't hear anything. So what you're looking for is there airway edema? This is what you're concerned about. The longer someone's on an oral ET tube, the more airway swelling they're at risk for. FEV? No, it's something else. It's no, it's not FEV. I will figure it out and come back to you guys. I'll put it in text down here. I'll find out tonight and let you know. This one. This is the one I'm looking for. Okay. All right. So typically what I do on the cuff leak is I will ask the RT to check for a cuff leak. And if they can find it, I am perfectly good with that. But a lot of people want to hear their own cuff leak. So if you're doing your own exam, to me, the easiest way to do it is just to listen for it. So you take your 10 ml syringe, you connect it to the pilot balloon, you deflate it, and you listen. You should be able to hear air. You might even be able to hear phonation or secretion, like airway sounds. That's pretty indicative. You've got a good cuff leak, you're good to go. If you don't, then it gets a little hairy because, and I would say in reality, it's probably 50% of the people. So it doesn't mean that you can't extubate. You just need to try and come to a good understanding of why you think they don't have a cuff leak in order to decide if you're willing to accept this kind of risk or not. And it's going to vary, right? Because the patient who came in with ACE-related angioedema that has oral swelling as well as airway swelling, yeah, you're going to want those people to have a cuff leak for sure. Versus like, your overdose patient that's this little bitty lady that has an 8.0 tube in, which is probably pretty big for her airway. And you're probably just not hearing anything because the tube in and of itself, especially where the cuff is abutting the airway. And there's just not enough space for air to get through. This happens a lot of time. So, and the reason you can tell the difference is really just looking at the whole picture. What is the diagnosis like I just talked about? Is it something where there weren't any airway concerns? They haven't been on an event for very long. It's probably less likely that you truly have airway edema. I think I wrote, I write it better than I say it. This test, while specific, lacks sensitivity, meaning if there's an air leak, yay, they pass the test. But if there's not an air leak, it could mean a number of things. And airway edema is just one of those things. So here's what I said to troubleshoot if it's negative. Number 1, is the cuff truly deflated? Make sure the bite block, okay, most tubes now have a built-in bite block to keep them from biting down and preventing air from going in. So this bite block can move though, to allow you to put it, somewhere. They're usually attached to the ET tube holder and they can move based on, everybody has a different depth that they need. So they move. So has it migrated down and it is occluding the pilot balloon line? If it's occluding the pilot balloon line, then if you try and withdraw air, you might not get anything back. or you're pulling back and getting tons of air, but you're not actually deflating it and it's still up. So make sure the bite block is well out and that you can follow the pilot balloon line as far back as you can. The next thing is I look at the vent to see, okay, so when you deflate the balloon, are you seeing volume loss? You should see a little bit of tidal volume drop because what's happening is the ventilator is blowing air in, but it's not staying in the air in the lungs and just below the airways because there's no cuff preventing it. So it'll come back out. So your volumes, you may, like say before you deflated it, your tidal volumes were 500, pretty standard. You deflate it and suddenly your volumes are like 350, 320. You probably have an air leak because you're losing volume somewhere. So it's got to be going up. This also, by the way, if you're getting low tidal volume alarms on the vent, this is the first thing I think of is the cuff blown. Just FYI. The next step would be to get a chest x-ray. Is the tube in the correct position? Is it... I think I read this in one of the articles, and I've never really even thought about this, but the gastric tube, the OG tube or the NG tube, whatever you got, is it in the right place? Because sometimes if it is migrated down and is sitting like in the trachea above the cords and impeding on the cuff, it could be preventing air from coming up. Generally speaking, you know this because you've gotten an x-ray to confirm those in the right place, but just FYI, could be. Most common thing is, like I said before, big tube in a small person. The diameter of a tube is just preventing it from hearing any air leak. You can consider a laryngoscopy to look in the oropharynx and the airway. So this would be like, in reality, this like taking a McGrath that has a video stylet attached to it and sticking it in the mouth and looking to make sure that nothing's kinked in there and as far down into the airway as you can see, to just visualize it. And you might at that point be able to appreciate some airway edema, some oropharynx or even further down, like you're not going to see the vocal cords because the tube's going to be in the way, but just above it, just superior to it, you might see a lot of edema, a lot of what looks like just tissue. If you're seeing that, then yeah, they got some airway edema. And lastly, you could consider a CT of the neck if there's a known issue of malignancy, infection, or swelling. Then if you think that there is a potential and or you don't have a really good benign reason for why you don't have a cuff leak, you put them on steroids for 24 hours and then you recheck. And most always you're going to have a cuff leak at that point. Okay, so that's number 5. Number 6 is any pending surgeries or procedures. I think this one kind of goes without saying, but you know, you got to put it in there. If there is anything coming up in which the patient is going to need conscious sedation and or surgery, like general sedation and anesthesia, just leave the tube in until you get it done. Common things that we'll see are like need for repeat EGDs, scopes, TEEs. Where I'm at, our cardiologists will do TEEs at the bedside. And because of that, they majority of the time, they're going to need some kind of sedation. So just go ahead and get that out of the way. Your bacteremic patient, go ahead and get your TE before you extubate them. It's just a whole lot easier when you have a secured airway to give conscious sedation. And surgeries, of course. If you have like a neck fash or abdominal washout that needs to go back, just coordinate what needs to be done to make it easier for them. MRIs, that's another big one. Say you have like a patient where their diagnosis and or their prognosis is really hinging on an MRI. You're going to want to get that MRI before you extubate them because you don't know what you're going to get once you extubate them, whether or not they're going to be able to comply with a, anywhere from 20-minute to hour-long procedure. People at best, even when they're in good health, have a hard time tolerating MRIs and need sedation. So go ahead and try and get that first. But having said that, I don't know how it is in your shop, but where we're at, MRIs take a long time. Sometimes it's like several days to get it done. I don't know that I would delay an extubation just for that, unless it was like really, really crucial. Like everything is hinging on this MRI. Stick in the eye again. Then I might. So why did I put that back? I didn't need to do that. Okay, next. What is the failure plan? So, and this is really kind of the last thing, because going back to that initial talk in the beginning about how we want to keep always be trying to extubate. And a lot of times we're going to extubate knowing that there's probably a pretty darn good chance that this isn't going to go well. That's okay. As long as you have a great, like well thought out, everybody's on board plan for if they don't pass. This is typically going to be like a goals of care discussion, and it's going to be different for everybody based on what's going on with them. But a very, very common thing in my world is going to be your sort of that scenario I talked in the beginning. That's your older person and or your person with dementia, somebody who is in like chronically ill health, who ended up getting intubated for whatever reason, but the patient maybe never wanted to be intubated, or the family's like, I don't think this is the right course for him. And so if we take this tube out, they wouldn't want to go back on it. Those are the people that you really just want to have a great discussion with the family and say, here's what I'm seeing. Here's the percentages that they'll do well, and here's the risks. And we're going to do this because it's the right thing. It's the best guess. But on those kind of patients, you want to have a higher index, a higher concern that they're going to fail because you can't go back to it. As long as you have a plan in place. We are for reintubation. We are not for reintubation going into this. And what are my steps if I fail? Am I going to go back to CPAP? Are they okay with that? Is this somebody that, like, say it's been a prolonged neuro thing, and you're just like, a lot of these strokes are like this. Their GCS is right around 8 or 9. They've got some secretions. You're not real sure because you can't really get them to cough for you. And you're like, it's a real guess. These are the ones, the discussion I'll have with the families is like, okay, I think they're pretty much ready, but it's kind of a 50-50 shot. And if you do want this person reintubated, say we take it out and they fail, there's a really good chance we're just going to go ahead and go straight to a tracheostomy. And are you okay with that? And we bring trach talks into this so much because for a lot of people, trachs are a line in the sand. For whatever reason, they're just like, you know what? I'm okay with being on a ventilator for a week, but I would never want to have a tracheostomy. You just want to know that because it's a decent chance they're going to need one. And the other thing is you want to assess how difficult was this person to intubate. So I always look back at the procedure note. Typically speaking, when somebody has a difficult intubation, it is all over the chart. There are great records for it, and in advance because people are going to tell you in the sign out this is a difficult intubation. If they're a difficult intubation, this is also the person you're going to have a much higher threshold for. Things need to be really pristine before you take it out, or you can be willing to do a crike, an emergent crike. So as long as you know what you're getting into. So that's the long of it. The short of it, let me go through the quick checklist. Primary problem resolved or significantly improved, check. No pending procedures or surgeries, check. Neuro check, check. Look at the vent settings while on the SAT-SBT trial. Minimal to no sedation. Pressure support sufficiently low, which ranges, but an average is less than 5. FiO2 less than 30, PEEP less than 5. RSVI less than 100. No apnea alarms. Respiratory rate is sufficient at least greater than 12. Look at the monitor. What are their hemodynamics? Is the heart rate good for them? Is the respiratory rate low? Is the blood pressure stable? What's the SpO2? Then you do the mechanics stuff. Ask them to lift their head off the pillow. Ask them to take a big, deep breath. Ask them to cough. Check the secretions, the consistency and the amount. Assess for the presence of a cuff leak. Establish reintubation plan versus goals of care. And then liberate them from the ventilator. And you win. And this is how it goes. And sometimes it's a slam dunk and sometimes it's not. And sometimes it is literally a guess. But I really love when I work with physicians who are always very aggressively trying to get someone off of a ventilator, because it's not always the case. The other times that this can be super helpful is if you round in a unit where you have a lot of surgical cases or cases in which the patients quickly turn around and there's sort of like these protocols in place for the nursing staff to just extubate whenever they're ready. 9 times out of 10, it's perfectly fine. It's perfectly fine because the anesthesia is worn off and they're doing better. Sometimes there's underlying pulmonary physiology though. So if you have this checklist in place and you can just go in there, hang on just 5 minutes before you pull the tube. Let me just run through it real quick. It won't take you long at all. And you'll have a much stronger sense of comfort level in taking that tube out, because you don't want to be me. You do not want to be the new NP who makes a catastrophic mistake that could potentially end up in someone dying. I mean, because that is the reality. This is life and death. So it can be bad. Not always. Most of the time you can just retube them, but sometimes it takes a minute. And is it worth that risk? So that is my parable for the day. Fable, I don't know, using the wrong word there. But so that's all I got on extubation. Again, I love it because it is very objective. You just go bam, 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 one thing after another. If you want to, I think I may have put a link to this in the description of this video. If not, I'll add it on the back end, but you can just print off that checklist. And that's it. Anybody have any questions, burning thoughts, things they want to talk about? Right at an hour today. Whoa, I am doing really good today. Next week is job options for adult gero acute care NPs, like work settings where you can work. I'm about done with it. That's really all I got. Super unexciting video today, but hopefully it was helpful to you and will be helpful to your practice and your training. Scott, I hope you get some great nutritious vegetables. Alex, thanks so much for coming. And I will touch base with y'all next week. Have a good night. Thank you for all this great information. We'll definitely rewatch. You're so great. Thank you.